We're now going to begin a review of diseases of the endocrine system. Vignette number 1 says a 62-year-old woman was drinking her morning cup of coffee at the same time she was applying her makeup. And she noticed in the mirror that there was a lump in the lower part of the neck visible when she swallowed. She consults you for this, and on physical examination you ascertain that she indeed has a prominent 2 cm mass on the left lobe of her thyroid, as well as 2 smaller masses on the right lobe. They are all soft and she has no palpable lymph nodes on the neck. So what is the issue that is raised by the presence of a mass on the thyroid gland? As a general rule, when we are concerned about cancer, that doesn't manifest itself with thyroid function changes and vice versa. So if you read a vignette on the exam that describes the changes that you associate in your mind with hypo or hyperthyroidism, you are not thinking that cancer may be the problem. And if you are told in a vignette that there is a lump in the thyroid gland, but there is no indication about any functional changes, then you're thinking, is that a cancer? But as it happens, the incidence of cancer in thyroid nodules is very low, and it would not be justifiable to do a thyroidectomy on every patient that has a palpable lump in the thyroid. And the way we select who gets a surgical intervention nowadays is by doing an FNA. So we do the fine needle aspirate. If the pathologist says these cells look benign, that's the end of that. If the pathologist says this is a cancer of the thyroid, then we do a thyroidectomy. And if the pathologist cannot tell, which may happen with follicular tumors, if the reading is indeterminate or the reading is follicular neoplasm not otherwise specified, the pathologist is not sure, then we also have to do a thyroidectomy. So the answer obviously for this vignette is let's go ahead and do an FNA, a fine needle aspirate, of the most prominent of those masses that are felt on this lady's thyroid. Well, as we move to vignette number 2, we see an example again of how we select who gets an intervention. A 21-year-old man is found on a routine physical examination to have a single 2 cm nodule on the thyroid gland. His thyroid function tests are normal. An FNA is read as indeterminate. Now that reading indeterminate on the FNA requires then that surgery be done to be sure that what he has is not in fact a thyroid cancer. The operation would typically be only a lobectomy on the site where that nodule is, and then we can get the path diagnosis. Let me now move to vignette number 3. A 32-year-old woman has a thyroid lobectomy done for a 2 cm mass that had been reported on NFNA as a follicular neoplasm not otherwise specified. The specimen is given for frozen section to a pathologist with a great deal of experience on thyroid disease and in the reading of frozen sections. The intraoperative diagnosis rendered by the pathologist is follicular cancer. So this lady was explored because the FNA was unable to differentiate between a benign follicular adenoma or a malignant follicular carcinoma. Now that the specimen has been given in its entirety to the pathologist during the operative act, we now get the information that this is a follicular cancer. The correct answer then for this vignette is a total thyroidectomy should be completed. Let me talk a little bit about the treatment for thyroid cancers. There are 4 types of thyroid cancer: papillary, follicular, anaplastic, and medullary. The papillary is not a very aggressive cancer, and almost any kind of surgical resection done for a papillary is bound to have a good outcome. The follicular cancer, on the other hand, is known for its ability to have blood-borne metastases that may show up in the patient at a later date. If that were to happen, it would be extremely useful for that patient to have no thyroid tissue left at all in the neck, because the follicular neoplasm is a functional tumor. It can trap iodine and attempt to make hormone. It doesn't do it effectively enough to, in fact, change thyroid function on a patient. But in the absence of normal thyroid, the follicular cancer would become the most effective iodine trapper in the body. So by doing the total thyroidectomy now, we can then in the future, if we have evidence that they are metastases of the tumor, treat them with radioactive iodine, because there'll be no competition from normal thyroid tissue to trap that radioactive iodine. We now move to vignette number 4. An automated blood chemistry panel done during the course of a routine medical examination indicates that an asymptomatic patient has a serum calcium of 12.1 in a lab where the upper limit of normal is 9.5. Repeated determinations are consistently between 10.5 and 12.6. The serum phosphorus is low. This is the way that parathyroid hyperfunction shows up nowadays. In an earlier time, there used to be a mnemonic that we gave to the medical students to help them remember parathyroid disease. And we talked about the disease of stones and bones and abdominal groans. Because people who had excessive production of parathyroid hormone had renal stones, had cystic lesions in the bones, and they frequently developed pancreatitis and peptic ulcer disease, giving them abdominal pain. But with the introduction of the automated blood chemistry analysis in the labs, nowadays when we send a sample of blood to the lab for any kind of chemical determination, we typically get a lot of additional information from the lab. In other words, they measure the chemical that we wanted measured, but they also measure another 10 or 12 or 20 because it's easy for the machine to do it. So we end up with this kind of presentation. An analysis of the blood was done, and lo and behold, big surprise, the calcium is higher than it should be, the phosphorus is lower than it should be. And that brings to mind excessive parathyroid hormone production. So given that presentation, we proceed then to measure the parathyroid hormone. It should be low if the calcium is high, it should be high if the calcium is low. There is a direct feedback there. If we realize that when we check the hormone, the level of the hormone is high at the same time the calcium is high, that's abnormal. Most of these patients have a parathyroid adenoma. And nowadays, we can localize that before we do surgery. We ask the nuclear medicine people to do a System.flv scan. This is a substance that is used by the parathyroid gland in its metabolic activity, and by making it radioactive, we can then do a tracing, a scan of the neck, and the nuclear medicine specialist can tell the surgeon the gland that is hyperfunctioning, the one that has the adenoma, is the upper left or the lower right, the specific gland. And that way, instead of having to do a neck exploration to look at all 4 glands, we can zero in on the one we know has the pathology and remove only that one. We're now on vignette number 5. A 32-year-old woman is admitted to the psychiatry unit because of wild mood swings. She's found to be hypertensive and diabetic and to have osteoporosis. She had not been aware of any of those diagnoses beforehand. It is also ascertained that she has been with amenorrhea for some couple of years and also needs to shave her face. She has gross centripetal obesity with moon facies, a buffalo hump, and thin bruised extremities. And a picture from 3 years ago shows a person of very different, more normal appearance. In fact, a good guess is when you get this particular question on the exam, the first thing you might see is in fact 2 pictures on the screen. One picture will be the face of a lovely looking young lady, and next to that there'll be the picture of a monster. And when you look at the monster, you realize that monster has a round face, is very red, is full of pimples, it has hair. And that individual also has a buffalo hump, a supraclavicular fat pads, and perhaps if you see a picture of the entire person, you realize that there is a fat trunk with thin extremities, with stria on the abdominal wall. And then, of course, the vignette will alert you to the fact that this person who looks so grotesque is the same individual who a year or 2 earlier was the other picture that you see on the screen. And then you get the additional information that I already read. There is diabetes, there is hypertension, there is amenorrhea, there is osteoporosis. And all that adds up to Cushing's syndrome. It's a very characteristic presentation. This is an individual that has Cushing's syndrome or Cushing's disease. Now, the workup for Cushing's is a little complicated. There are a couple of ways to do it. One way to do it is to rely on dexamethasone suppression tests. We would begin with a low-dose suppression test. If the person suppresses at a low dose, the disease is not present. It's simply a person who looks that way. But if she does not suppress at a low dose, then she indeed has Cushing's disease. And then we need to differentiate, is the problem coming from the pituitary gland, from a microadenoma, or from the adrenal glands, an adenoma there. And then we repeat the suppressions at a higher dose to distinguish those two. If she suppresses at a higher dose, the problem is from the pituitary. If she does not, it's a tumor in the adrenal gland. There is another way to do this, and by the way, you have a lot of detail in your notes, both on the narrative part and in the comments that follow this vignette on your notes. But there is another way to do it. The Mayo Clinic advocates a diagnostic algorithm that relies primarily on a 24-hour collection in the urine for free cortisol levels. Patients with this disease have levels that are 3 to 4 times the normal, and then relies on measurement of corticotropin to differentiate pituitary adenomas from adrenal adenomas. I personally think that it's not really necessary for a physician to memorize the workup of Cushing's, because Cushing's is very rarely seen. And I think the important thing, and therefore what I think the exam will stress, is your recognition of the disease. You should be able to look at the pictures, hear the description, and say, that's Cushing's. We now have some pictures for you on the screen. The first one is the famous moon facies. You're looking now at the very typical appearance of the face of a patient who has Cushing's syndrome. You see that it's round, it's full of fat, it looks reddish. This is very characteristic. And if you had next to that a picture of the same patient a year or 2 ago looking very different, you would have a very helpful diagnostic clue. Well, here is another picture showing the stria that we see in the abdominal wall, and also a picture of all the ecchymotic areas that frequently we see in the thin extremities of a patient with Cushing's. You might notice in this vignette how thin those arms are in comparison with the trunk of a patient that is right behind. This is a patient who has the famous centripetal obesity. And because of the damage done to the blood vessels by the catabolism of the proteins, they very easily bruise. And there you have it on the picture. Our next vignette now is vignette number 6. A 28-year-old woman has virulent peptic ulcer disease. Extensive medical management, including eradication of Helicobacter pylori, fails to heal her ulcers. She has several duodenal ulcers in the first and second portions of the duodenum, and she has watery diarrhea. This is a pretty good description. of a gastrinoma, Solinger-Ellison syndrome. This is not a common disease. In fact, it's quite rare. But for purposes of the exam, it's very easy to recognize. It is a patient that has virulent peptic ulcer disease. All of the standard treatment has failed, including the eradication of H. pylori. The ulcers are more extensive than they normally would be. There's not one, but 2 or 3 ulcers. The ulcers are not only in the first portion of the duodenum, but further down. And finally, there is that watery diarrhea. So if you encounter this question on the exam, you immediately look for the answer that says, let's measure serum gastrin, since that is a hormone that is elevated. And then after that, we do a CT of the pancreas, looking for the tumor. And if at all possible, we resect that tumor. We're now on vignette number 7. A second-year medical student is hospitalized for a neurologic workup for a seizure disorder of recent onset. During one of the convulsions, it is determined that his blood sugar is extremely low. Further workup shows that he has high levels of insulin in the blood with low levels of C-peptide. So it has been established already in this case that the alarming, impressive neurological findings coincide with a very low blood sugar. And so the challenge that remains is to decide, why is there a low blood sugar? If you look at the chapter on hypoglycemia in a standard medical textbook, there'll be a long list of potential causes for low blood sugar. But many of those on that long list are problems that are otherwise evident, like liver failure, like very large retroperitoneal sarcomas, that you already know the disease is present because of the many other manifestations. So when it comes to only hypoglycemia, for no apparent reason, essentially there are 3 possibilities. There is an insulinoma, there is reactive hypoglycemia, or the patient is injecting himself with insulin for some secondary gain. The lab is very helpful to make this differential diagnosis, because the insulin we make in our own pancreas comes along with a byproduct called C-peptide. So if the lab says to you the patient has high insulin levels and high C-peptide levels, that insulin is coming from the patient's own pancreas, not from a vial from the drugstore. And if that were the case, your further differential diagnosis is it an insulinoma or is it reactive hypoglycemia? And for that, the history gives you the answer. When does the problem occur? A patient that has an insulinoma typically has a neurological findings during fasting, before breakfast, if he missed lunch, if he's late for dinner. Whereas on the other hand, the reactive hypoglycemia is the very opposite. It occurs after a big meal. The patient eats a big meal and 20 minutes later, his pancreas has overreacted and he's hypoglycemic. But on the other hand, if the lab says insulin levels are high, C-peptide is low, like this vignette, that tells you this insulin didn't come from the patient's pancreas. This insulin came from the drugstore, from a little vial. This is self-administration of insulin. So in this case, there is no point in doing a CT of the pancreas, which you would have done if you thought it was an insulinoma. But actually what you need here is a psychiatric evaluation to find out why is the patient resorting to self-administration of insulin for secondary gain. Well, let's move to the next vignette. A 48-year-old woman has had severe migratory necrolytic dermatitis for several years, unresponsive to all kinds of herbs and unguents. She is thin, has mild stomatitis and mild diabetes mellitus. And this happens to be the presentation for the other endocrine tumor of the islands of Langerhans, the last one to be discovered and described, the glucagonoma. There is mild diabetes, as you would expect for someone who makes a lot of glucagon. But the most impressive finding on these individuals is that migratory necrolytic dermatitis. And so if you read this on the exam, you should immediately recognize that's a glucagonoma. We obviously need to determine the levels of glucagon in the blood and then do the CT scan of the pancreas looking for the tumor that makes the excessive amount of glucagon. I might add that if we find that these endocrine tumors from the islands of Langerhans are inoperable, that we can provide some help to the patient by the use of somatostatin or streptozotocin, because those can be helpful in managing the problem.